Hello, everybody. This is Aurika Savickaite, co-founder of helmetbasedventilation.com, and I'm so happy to have here Rachel Carragher. She's a respiratory therapist and a manager for her unit, and she is a champion of the helmet-based ventilation. So, Rachel, can you introduce yourself to the listeners here?
Sure. My name is Rachel Carragher, and I am the manager at UMass Memorial Hospital in Worcester, Massachusetts.
And I did do some, I looked up on some of the works that you did already in your field, and I saw some articles that are posted in Respiratory Care journal, also some of the posters where you are always involved in some research and trials. So no wonder why you actually doing a helmet-based ventilation in your hospital, and you are a leader for that system and its implementation. So can you tell me a little bit more, how did you learn about it? Where did you learn it first, and how that whole process went in your facility?
Sure. So Dr. Mateus and Dr. Rebecca Bauer, they work in anesthesia. They're anesthesiologists, and they were talking to some anesthesiologists in Italy, and this is where it kind of came from. And so Dr. Bauer took on the role of these helmets, and she actually purchased them with her credit card. And they were delivered to her house, and then she brought them to my office, and that's how I ended up with the helmets. So after I had received the helmets, and I did some, I was reaching out to the physician in Chicago, and myself and Dr. Bauer, and then Dr. Bielik, Christine Bielik, who is my medical director. They were true supporters of the helmet with me, and helped me on a physician level to get buy-in from the physician. So
that's nice. You got connected actually with the Italian physicians, so they shared their experience and their setup options for the helmet, and also you did talk with some physicians in Chicago. Did you talk with University of Chicago doctors, Patel and Dr. Press?
The first doctor you said, yes.
Yeah, Dr. Patel, yes. So she's the one that published the paper about the helmet-based ventilation. Nice. And so which helmet did you buy? Is that the two-piece helmet that you put the one piece on and the other one, okay.
Yeah. So originally when we received the helmets, myself, my director of respiratory care, and our medical directors, I have two, Dr. Paulo Oliveira and Dr. Christine Bielik, and Dr. Rebecca Bauer, who again is from anesthesia. We all came together as a group to try to figure out the best way to utilize these helmets for the patients. And at first we were trying to do it through a BiPAP machine, which was kind of really loud for the patient. So then we ended up, all the patients who we used the helmet on, which we had 9 patients we put the helmet on, we used the high flow setup. So 70 liter flow meter, and then we added another flow meter, a 15 liter flow meter, just to give us extra flow if we needed that flow.
Okay, so you kept it around 70 up to 100 liters per minute flow, something like that?
Yeah, never went up to 100.
Okay.
Usually I would say around 80 to 85, and it wasn't, it was more that I think the patients would get warm in there, and so I think the flow for them just would help them, not be so hot. Just
to get that extra wind, that really helps. And it helps with the, sometimes the helmets will get foggy too. So if you increase the flow.
Yep, you definitely need mouth flow. So that's, one thing that we would obviously go over with education with our staff is that if there was any fogginess, you definitely would need to go up on the flow.
Okay. So did you use any humidifier or none?
No, we didn't use any humidifier. No, we didn't want it any hotter than it already was. So nope.
And that's what I see, especially if the helmets are used somewhere where it's humid and hot in, outside the U.S. and where we don't have air conditioners inside, they get foggy so quickly without using humidifiers. So like you said, increase the flow, and that's gonna get the fog out. Now, all this happened, what month? How long ago?
Oh, goodness. I'm going to say March. Probably in March we got these helmets, March or April. I think we started looking at them in March, and they were probably delivered in April.
Okay.
And then the first patient I put on, hold on, I can get that information.
You used it all for the COVID patients?
All COVID patients, yep. So all the patients we had put on the helmet were positive COVID, yes.
Okay. What approximately the age of patients was?
Anywhere, I think my youngest patient was, the average, I'm going to say we're in the mid-50s.
Okay. And you did it in ICU settings, right?
Yep, just in the ICU. We
Nice.
never started it in the emergency room. The patients generally would come up from the emergency room on high flow, and we would try to initiate it once they got up to the ICUs. We would switch them over to the helmet.
And then how did you feel the, response to the helmet from other staff members, like nursing staff, nurse practitioners? I don't know if you have them on the unit, probably.
Oh, yeah. No.
Yeah.
So the first patient we put on, I believe was, so he was a 56-year-old male who came in, and he was in severe distress. And this was actually our third patient at this point who we're trialing the helmet on. And so when we put him on, it was funny because he turned the corner so quickly. He was actually sitting in a chair, FaceTiming his family. He was doing extremely well with the helmet. So we got a lot of buy-in from the nurses because they actually saw how well he improved.
Wow.
So that was great that the nurses in the ICU in one of our COVID units actually, witnessed how well this individual turned around. So any patient that came in, everyone wanted to put the helmet on, and there's definitely patients, who shouldn't go on the helmet, and then there are patients that should go on the helmet. So he did, he did well on the helmet.
And did you have any patients who didn't pass the helmet ventilation, who end up being intubated, and how fast did that happen? After how many hours of the helmet ventilation you saw that may not benefiting from it?
So I guess there's, when I go back and look at the data that I have, there's some patients that, there were two patients we went and put on that we just shouldn't have put on. They were, the minute we put them on, we had to take them off because they just couldn't tolerate the hood. And they were telling us up front that they didn't think they could tolerate it, but we still wanted to try it with them, and they just couldn't. And then we had, different scenarios. Unfortunately, the patient that I'm just talking about, now you have to remember, this was something that was trial and error for us. Okay. This is something that I took on. I'm trying to learn how to use this helmet. and to keep patients from not being intubated. And there wasn't many videos out there. So it was really us in my group trying to figure out the best way to put this helmet on and keep the patient from being intubated. And this gentleman that I'm talking about, like I said, he did extremely well when we put him on. And then unfortunately, of course, when I had talked to Chicago, they're in the same boat as us, is that everything happens on the night shift when there's nobody around. So unfortunately, there was a problem with his helmet, and now I've learned what it was, but at that time we didn't know what it was. Is that when they took the helmet off to let him drink, and when they put it on backwards. So then it kept popping off. And then unfortunately he had to get intubated because of that. And that was I believe day 3 or 4. And so that was truly a technical issue. And I'm not sure if he would have not got intubated, but he was doing really well. He loved the helmet. He thought it was working so well for him. And then, like I said, there was a technical issue on an equipment issue, and then they just ended up intubating him, unfortunately. So that was, a sad case. I'm going to say the majority of patients were on it for about 3 days, and then if they had to get intubated, would have gotten intubated. We did have one female who was on it for 7 days and then ended up going to high flow.
Okay.
And then that was our longest, was 7 days. But I would say the average was probably 3 to 4 days.
3 to 4 days. Wow. Well, that's for the COVID patients is they usually require long treatments for the health.
Oh, absolutely. And these patients were really, really sick, so, and I think that, when I tell people when they call me and ask about the helmet, it takes work. It's not something like, when we put someone on a ventilator, we intubate them, we put them on the ventilator, and obviously we check them and we do our checks, but the helmet definitely requires more work. And so it is time consuming in the beginning, and the unknown, the staff don't know about it, and them trying to learn it. Those are all obstacles that you just have to work through. So that can be a challenge.
That's a very good tip that you are giving to all the listeners here. You have to learn, you have to go over those bumps before you feel very comfortable using the helmet. And, this is why we put it on a website. I don't know if you had a chance to look at it, but we put it some protocols that are presented by Dr. Patel and also by Dr. Sarita from Penn University. And hopefully that's going to help other hospitals, because like you said, at the time when you started helmet-based ventilation, you had no guidelines from anyone. So you needed to figure that out. You needed to use your experience and your knowledge as a respiratory therapist to see how the system works and do the troubleshooting based on your observation, which is amazing. You are the pioneer of that, and you were able to use it for, did you say 9 patients?
We used it for, I think we actually had 8. We had 10 patients, but 2, like I said, they definitely weren't, they didn't want to go on it, and we literally put it on them and took it off of them. They just couldn't tolerate it. I think some of the challenges in the beginning were feeding patients, and then by the last patient we actually put on, we learned to take the NG tube, cut it, and use that as a straw, and we were able to feed our patients. So that was huge, because there was, the physicians were very nervous that their patients weren't being fed. And so we did put in a PICC line on another patient, the one who was on it 7 days. We ended up putting a PICC line on her. And then the other patient, like I said, we started feeding him right through cutting an NG and giving him Ensure like 3 or 4 times a day. So those were all things we learned. Other things that I think are important for people to know is pressure injuries. So, anytime you have any pressure, you're going to cause, you can cause pressure injury. So, I think one thing is making sure that when you're, taking the rubber the rubber pieces and trying to put the helmet tight, is making sure that I did see a video that now has it on the side rails. So you're not underneath the patient's arm. So you're not causing those pressure injuries. And then just really be careful around the patient's neck. And I don't think it's like a problem for patients who are on it, the 2 to 3 days, but the patient that we had on 7 days, she did have some redness around her neck. So one thing we learned was to make sure, you put, some sort of protector around the patient's neck.
And you use the duoderm. Did you?
Yep.
Locate? And actually it makes even feel much better. And it's less, it gives you less discomfort. And like you mentioned, the underarm straps. So that's what Italians are doing. If you're using the helmet for longer time, you just put the weight down on the underarm so it doesn't touch the patient at all. And I think like a 2 kilos, so what is it, 4 pound, 2 pound weight, or 4 pounds, sorry, my math. And that helps a lot too, to handle the helmet. Now, and then, so I know already the story, but what happened, you end up injured and you were not able to work, right? And this is when you feel like the helmet-based ventilation in your hospital was not used so much, and then
we stopped. So once I had my injury, we stopped using the helmet, and honestly our COVID cases were going down. So I planned my injury just perfectly for when the COVID surge was away, and then I get hurt. So, and then obviously now, we are we do have the helmet on hold at this point. We need to re-meet as a group and figure out if using high flow is the best way, or should we be using a ventilator. So we really want to meet as a group, and we look at what patients, are we going to put it on ARDS patients? Are we going to put it back on COVID patients? So that's something that me and our group will look at in the future for the helmet.
That's great. And now maybe it's the time where you can, keep using the helmet on your patients, non-COVID patients.
Right.
This is where, you're learning and you get that, you become more comfortable with the helmet system. And did you try to connect helmet to the ventilator pressure support?
No, we did not. No, but I do have a couple therapists who are very interested in attaching it to a ventilator. And I think the to know is that one thing that I don't think that is mentioned in many places is that there is an inspiratory side and there is an expiratory side. That's really important to note, because not everyone knows that there is a one-way on those helmets.
Mm-hmm.
I was just thinking of that.
Yeah, so the inspiratory and expiratory side. And some helmets we have actually access not just at the bottom of the helmet, but also on the top. Which ones did you use?
We use the ones on the top. So the ones on the bottom we actually capped.
Okay.
So it comes, the helmet arrives and then the caps that are on the side, they actually go on the bottom. And then we hooked up, corrugated tubing and obviously a PEEP valve and, filters. But it is important to note that there is an inspiratory side with a one-way valve, and then there's the expiratory side. So when I did some education with some of the other hospitals in Massachusetts, they weren't aware of that. And it's not, on the videos I've watched, no one really states that. So I think that's important to note.
Yeah, because some of the companies, they do have those valves. So there is you cannot connect the wrong way, otherwise it's not going to work. Now, did you try to prone the patients on the helmet?
No, we wanted to, we just weren't at that time comfortable doing that. So no. And we did give sedation to our patients to keep them comfortable with the helmet. I think that's another important thing, is that they're anxious, they're sick, they don't feel well, and then you're putting now we're putting this helmet on them. So we did give our patients Presidex and try to just make them comfortable during their time on the helmet.
And if any other tips for the patient's comfort on the helmet? While we
I think communication and speaking to them. I mean, the biggest thing is if you can, like I said, we were hesitant in the beginning to, let our patients drink just because we didn't know enough about it. But like I said, by the last patient we had, he was drinking every couple of hours, and I wish we had known that, that we felt more comfortable in the beginning to offer other patients to be able to drink. So just like a learning curve, but that's definitely a tip, is letting your patients get their nutrients that they need to make them strong.
Also, the patient education is an important piece, and we don't have very much in place right now that we can offer. We don't have a document where you can cover all these things about the helmet for the patient, so we don't feel anxious, so we understand how it works, so we know how to take that sip of water, because otherwise you can make a mess and everything. So so how the physicians looked at the helmet ventilation? Did they
No, they were willing. They were willing to try it. Like I said, we definitely had buy-in from two, from the anesthesia department and from the pulmonary department, because the anesthesia department is the one who purchased them and wanted to have these available in case we ran out of ventilators. And then on the pulmonary side, we had Dr. Oliveira and Dr. Bielik, who are our medical directors, that were Dr. Bielik and I were working very closely to figure, when we would be called to go evaluate a patient to see if we thought they were a hood candidate. So we had buy-in from those two disciplines, so it was nice, so that worked out well for us.
Nice. Do you have any tips for physicians, respiratory therapists who are willing to try the helmet ventilation? What would be like the biggest no-nos and the biggest yes?
So I think you need a super user. You need someone who is passionate and is willing to try new things. And that's probably the biggest thing, is you need someone strong from either your respiratory department, and I'm assuming any hospital that is using these helmets have a respiratory department.
Yeah.
So you need someone very clinically strong and who is willing to devote time to put something in place, and then be able to educate your nursing staff, your physician staff, your respiratory therapist. So it's work, but I mean, hopefully the outcome is that these patients aren't getting intubated.
Yeah, exactly. And this is what University of Chicago did. They actually offered a helmet to patients who already failed high flow nasal cannula. And we still had good results. About 35% of these patients avoided intubation. So these are very, very sick. And UFC, we had experience with helmets, so but still, you need to have that champion in your department and your unit, so you have everybody on the same page, including nursing. Like you said, a lot of things are happening at night because you have less resources, and with the new technology there, you want to make sure that we are getting all this education hands-on and following the protocols. So again, a lot of information now is on the website, and I don't know, Rachel, if you had the chance to look at it, but there are like a ventilator settings for the helmet ventilation. and all the other like newest research that is coming from Italy also. Now I saw a lot of it still pending, but I hope to see the results very soon. All right, well, that was a great interview. Thank you so much, Rachel. And what I want to say to all of you, well, kudos to you, Rachel. This is amazing. We need more like you in U.S. hospitals. As we know right now, COVID cases are very high in the Southern Hemisphere, and I can tell you that a lot of hospitals there are also implementing helmet-based ventilation, and they are learning the same thing that you learned during during the April month. They are learning right now. So this interview is going to be great, so I can share it with them and they can learn and troubleshoot some of these things that are happening with the system, which is normal. So we all have to go through that learning curve, and I hope we can save more lives.
Yes. Perfect. Well, thank you.
Thank you, Rachel.